Good day and welcome to the Healthcare Data Workgroup webinar. At this time, all participant lines are open and unmuted. To prevent background noise during the presentation, please be sure to use the mute feature on your phone to self-mute your line until the conclusion of the presentation. You will have the opportunity to ask questions at the end of the presentation if time permits. Please note this call is being recorded. I will now turn the presentation over to Dr. Jennifer McNeely. Dr. McNeely, please go ahead.
So we're going to be talking about usability testing of electronic health record tools that we're building in the context of the study, which goes by the pithy title, A Phased Implementation, Feasibility, and Proof of Concept Study to assess incorporating the NIDA CTN common data elements into the electronic health record in large primary care settings, or the CDER-PC study. So I'm going to be joined by Joseph Kannry, who is the co-PI on the study and the lead technical informaticist. He is a professor at the Icahn School of Medicine, and Andre Kushniruk, who's working with us as our human-computer interactions consultant, and he is professor at University of Victoria. And I'm Jennifer McNeely. So to give you just a brief outline of the talk, I'll give you a quick overview of the study so you know what the context is. Then Dr. Kannry will give an introduction to usability and usability testing. Then Dr. Kushniruk will talk about data collection and analysis of usability data. And then each of us will talk about, from our different perspectives, about lessons learned from this process for this study. And I'm going to suggest we have a lot of material to cover. We are going to leave time at the end of the presentation. I think we'll have at least 10 to 15 minutes for some discussion. If you have questions, like to clarify in between each of our presentations, go ahead and raise your hand or come in with those questions. But for the discussion part, probably better to hold it until each of us has presented. So an overview of CTN 62. So NIDA selected common data elements to provide standardized substance use measures in EHRs. And so the common data elements, or CDEs, in this case are validated screening instruments to identify unhealthy alcohol and drug use. So here we're using the single item screening questions for alcohol and for drugs. And then we're using the audit and DAS-10 as a second screen for those who have an initial screen positive. And the goal of this study is to incorporate the CDEs into the EHR in a way that they will actually be used in practice. And that means developing an implementation strategy and tools to support their use and to support the clinical interventions that should follow from screening results. So this is a 4-phase implementation study, and it's taking place in the primary care clinics of 3 large health systems, Mount Sinai, Mass General, and OHSU. And we're going to be talking mostly about Mount Sinai, which will be the first, which is basically where we're working to develop the first round of the screening tools, and will be the first site to go live in January of 2017. So the 4 phases of the study are, we began by interviewing and doing focus groups with all the various stakeholders in the clinics, and that helped us to develop what the workflow would be for screening. And then we progressed to building and testing the screening tools built into the EHR and the clinical guidance tools. And those are what we're going to be talking about today. So the usability testing portion is phase 2, which we began in the spring of this year, if I remember correctly. And we'll be talking about the sort of iterative development process there. Phase 3 will be to implement these tools and the screening protocol at the Wave 1 clinics, the first of which is at Mount Sinai. And then in phase 4, it'll be implemented at the Wave 2 clinics. And so the number of clinics varies by health system. Mount Sinai will have 2, and Mass General will have 5 by the end of the study. So the workflow, this is the workflow that we determined for the initial Mount Sinai clinic. And I put it up here not to dissect it, but just to sort of point out that there are multiple, even for a relatively simple workflow like this, there are multiple points where we would want to prompt or to facilitate an action by the various providers. So here, the patient comes in, the medical assistant would see a BPA, which is a best practice alert, telling them that a patient is due for screening if they hadn't been screened in the past 12 months. And then if the screen was positive, the MA gets alerted to do the follow-on questionnaire, either the audit or DAST, and the MD receives an alert that the patient screened positive. Then we want the MD to look and record the audit or DAST score, and then to, if it's moderate risk, perform a brief intervention, if high risk, perform an intervention, but also to make a referral to the social worker who would do more assessment and refer the patient for treatment as indicated. So this is our usability testing process. We've done 3 rounds. And in the initial, we built a prototype and then tested it in round 1 with faculty. This is also a resident practice at Mount Sinai, so we tested it with both types of MD users and with the medical assistants. And what we found was that the screening portion of what we were building went easily for the medical assistants. But we detected sort of some early issues with the workflow that what Epic was triggering did not match the regular clinical workflow, in particular with respect to when it was telling the provider to order a social work consult, for example, right when they got the screening result. Whereas actually in practice, if you're seeing the patient, you would talk to the patient first and probably put in that order as you're wrapping up your visit, as you're putting in your other orders for the day. So we made adaptations based on that. In round 2, we were able to come up really with quite a creative workaround to make that alert to the provider, to make the referral, to have that come later in the visit at a logical time. And that was where we ran into just the limitations of Epic's functionality, and the IT team came up with really a good solution to it. And then, so for round 3, we had been building mostly text to help guide the brief intervention. In round 3, we tested also a smart set to guide the brief intervention. And really, this highlights what, to me, has been one of the most challenging things in this process, which is that the different providers have different styles of using the EMR. And so we were trying to accommodate sort of the smart set users and the dot phrase users for those of you who work in Epic. And it's challenging to sort of match those different styles, and we can talk about that more a little bit later. But so first, I'm going to hand it over to Dr. Kannry for more explanation about usability testing.
Thank you, Jennifer. I'm going to give an introduction to usability. What is it? Why does it matter? What's the science behind it? And then Andre will go into depth on what the actual methodology is, and then a little bit later, Jennifer, the 3 of us will wrap up with Jennifer. Usability has been studied in computer science information technology for decades. This is not something new. This is not something that's come out in the last 5 years or decade, though some will make you think it has. It's sometimes called human-computer interface or HCI research. It's best defined as the ease of use for humans of a system, and maybe someday that won't be as obvious. Usability equals usable and useful. You could also argue includes safe. I get this definition of usability from Andre, and I think it's a very good one. So one of the questions, sorry, I skipped a slide. One of the questions that you're asking with usable in terms of information systems. How easy is it to use? How efficient? How easy is it to learn? How enjoyable? Now, these questions you'll see underlie studies in the field, underlie results, underlie a lot of it, and you'll see them popping up over and over again. So that's because they all tie back to usable when you're discussing usability. And also, does it help you in your day? An excellent example of this is a study that I quote by Mark Wiener, and I always have the wrong guy every time I go up to him at a conference, on, for computer-based provider order entry systems or CPOE systems. But he makes a very good point in the middle of it. Physicians look for three things when using HIT. Does it help me with my patients? Does it improve patient care? Not populations, my patients. And does it make my job easier? Using a standard, we did a research around the turn of the century using a standardized instrument, QUIS, which we're in the process, Andre and I and a few others, of trying to update. It's not our instrument, but we think it needs to be brought up to the early decades of the 21st century. And it helped us assess user satisfaction. And we found how staff were dissatisfied with the commercial system when compared to the VA order entry system, significantly dissatisfied. We found the satisfaction was correlated with the ability to perform tasks in a straightforward manner. Remember the questions I just showed you. I'm going to go back 2 slides. Easy to use, efficient. Does it help you in your day? Usability ties in satisfaction. If a system is not usable, you're not satisfied. But again, notice the emphasis on efficiency here. And a similar study in 1999 also found the ability to perform tasks was key in user satisfaction. It's a nice concept, okay, but why does it matter? It matters for 2 reasons, patient safety and user satisfaction. As I mentioned in the Murff Kannry study, our study, user satisfaction is affected by usability. So there's multiple task force studies coming out saying usability has to be part of design. Task Force on EHR 2020 by Thomas Payne, who was recently quoted on ABC News because of this task force. And usability issues can result in unintended consequences and patient harm in a task force by Blackford Middleton on patient safety and quality of care using EHRs. Both of these emphasize the need for usability. Does usability cause patient harm? It does. Example, and this is from a book chapter by Andre Roskapel and I, alphabetizing dosing choices for medication dosing. We can argue why they wrote out the names, but in the programming behind, they alphabetized the words so that 845196732 was meant to be 1 through 9. Imagine trying to pick the correct number. Imagine that there was no usability testing of this at all. It was a programmer. Imagine no known allergy and no known drug allergy and multiple allergies all on the same list because they all were recorded at some time, and it's nonsensical. Imagine that the no allergy option is available and there's a list of known allergies. I mean, this is just unacceptably dangerous systems. Now, many agencies, federal, have been trying to incorporate usability into meaningful use, into standards, into certification. And the National Institute of Standards and Technology recommended that EHR should be tested for usability. They came up with a series of rules. What's interesting is the rules they used date back to at least 1995 or earlier from a gentleman named Nielsen, who had 10 heuristic rules for usability. They essentially took his rules and made them as part of their requirements. His rules include visibility of system status. So when you're during this presentation or anything in Windows, you notice you see lots of balls spinning, clocks moving. It's telling you something is going on in the system. iOS, iPhones, it's sometimes a little bit not clear that something's about to happen, though they've gotten better at that. Match between system and the real world. So there's no such concept as log on in the real world, so you can't, it's hard to make something on a device that looks like what you would expect in the real world. But the point is, you want things people are familiar with. So Apple did this in their versions of the iPhone, iOS before 7 and earlier. So books were stored in a bookcase. iBooks looked like books. The notepad looked like a notepad, etc. User control and freedom. People want to be able to do things in different ways and not be just guided and locked into screens. How many of you, and I'm sure you raise your hands if I ask, have used done a web survey or something on the web? It's like, I'd like to go to the next page. I'd like to go back, and you're locked in. Consistency and standards. We've seen this ourselves in our own applications. Apple's actually very good at it. Microsoft is too in general. But you don't expect the close symbol, the X, to be on the upper right, upper left, bottom, and all over the place. You experience this when you go between one operating system and another, but the consistency and standards, if it works this way here, it should be this way in the rest of the application. You should be prevented from making errors. In other words, you shouldn't be able to enter the patient weighs 1,000 kilograms. I mean, there's no patient that weighs 1,000 kilograms. And that's a good system. It prevents you from entering the wrong thing. Recognition rather than recall. What that means in English is I don't have to remember, I don't have to memorize, I don't have to pull out cards or books. I can look at the system and there's enough on the screen or enough around what I'm doing to remind me how to do something. Flexibility and efficiency of use. Epic's actually very good at that, the vendor, and they have 1,000 different ways to do things. But the key is it's got to be efficient. Aesthetic and minimalist design. Cockpits are not the ideal type of screen or application design. You want to help users recognize, diagnose, and recover from errors. How many times have you wanted to hit back, undo, and there's no such function? Or there's an OK button. I forgot to give that classic example that violates this, as well as before, control and freedom of when Windows gives you, your system's crashing. Okay, it's like, what do you want me to say? Usability is recommended or required by the Office of the National Coordinator for both Stage 2 and Stage 3 certification, meaningful use. Stage 2, they're recommending a user-centered design process and some of usability. Stage 3, they're actually getting to with effectiveness, efficiency, and satisfaction. So if you look at Stage 2, there's some of design. It's tasks. Again, remember we talked about tasks and efficiency, but it's not really testing the full gamut of usability. A study was done by, I think, Dean Siddig, Adam Wright, and a few others. I think Adam Wright was the lead author, on how well do vendors do today on user-centered design. There were 11 vendors. They looked at they lumped the responses into 3 categories: well-developed, basic, and misconceptions. They found, depending on the vendor, the staff that was responsible for usability ranged from 0 to 30. They found, I apologize, I got the authors totally wrong, so it's Rotwani, I'm thinking of another study, Fairbanks, Hettinger, and Brenda. My apologies to the authors. But how well do the vendors do today on design? Not great. They have some serious challenges. One is contextual workflow. It's great to test usability, but it needs to be in the context of the user with the rest of their workflow, doing their healthcare tasks and processes. And that's kind of sometimes hard. And breaking apart something and saying, what do you think of these, how we're displaying labs is fine until you realize, they're doing other things. How does it fit in? Participants, getting people to do this. They do not, our vendor, for example, likes to do usability testing only on site. And vendor leadership. There are vendors that they just don't want to, they just don't believe in this. They believe they've got to sell stuff and get market share. We did a study called ICPR, which was a randomized control trial looking at the integration of clinical prediction rules in an electronic health record. Clinical prediction rules are short rules validated on paper that say things like, these things mean you have a sore throat. We did multiple rounds of usability testing and development. This and some other factors, which include, active and actionable decision support, numerous context-sensitive triggers, dedicated training, and support from clinical and administrative leadership. These, along with usability, made for something that was well adopted, and our definition of adopted is the intervention is being used, and acceptance, you actually followed what we recommended. And these numbers are higher than most reported clinical decision support studies, and we think it's large part due to the usability testing and the development. We didn't just test usability and walk away. We made changes, much like we did in the NIDA study you're hearing about. Our concluding thoughts are, my concluding thoughts for the introduction are usability equals usable plus useful. It has a profound effect on user satisfaction and patient safety. It's recommended by several task forces and bodies. And I actually think every enterprise should have a usability testing lab, and that's not a very expensive proposition. It's a couple $100 and someone trained to do it. And with that, I'm going to turn it over to Dr. Andre Kushniruk.
Okay, thanks, Joseph, for that lead-in here. I'm going to be talking about usability in terms of data collection and analysis and the approaches that I've worked with Joseph on over the years, and also that were used in the project Jennifer's talked about at the beginning. Okay, so as Joseph mentioned, usability is a measure of ease of use and usage of a system. And we can look at it in terms of a number of dimensions and take it apart, so we can design studies to look at each one of these or one or more dimension. How easy is it to learn how to use or learnability? Is the system or technology effective? Does it do what it's supposed to, that is? Is it efficient? Does it take 20 steps when it should take 10? Safety was mentioned by Joseph. Is it safe? And last but not least, is it enjoyable to use or not? So I've come from the background where I've been applying usability engineering methods to healthcare IT. And usability engineering, we can say, are scientific methods to improve usability. So what are some of the main methods? One method is called usability inspection. And Joseph mentioned Nielsen's heuristics, those, be consistent, give error messages properly. Those are heuristics or rules, and one approach is to designers or evaluators to use those rules when evaluating a system to see if they match good design principles or when they're designing. Today I'm mostly going to talk about the other branch called usability testing, where we observe users, representative users, doing representative tasks using a system. So representative users might be clinicians, doctors, nurses, doing tasks using systems like electronic health record system. And I'll show that you can code the data for usability problems and present and summarize that data. And I'll show how to do that. And we also developed another term called clinical simulations, where it's like usability testing, where you have representative users doing representative tasks. But with clinical simulations, we try to make it a little bit more realistic so that the context is more realistic. An example I'll give is doctor-patient interaction studies. And also clinical simulations and usability testing can be conducted in real or realistic settings. And in situ would be taking the testing into the clinic or the office. So usability testing is a set of techniques to collect empirical data, as I mentioned, by observing users of a system carrying out tasks. And in doing this, it's really useful to video record or record what they're doing. And I'll show a screen with this in a minute, but we can record the computer screens when they're using a system, the audio of what the user might be saying, and we can also record the physical interaction. So we often ask users to use an approach called think aloud protocols, borrowed from psychology, where we ask them to think aloud while we video record them using the system. And the intent of all this is to provide information that can feed back to system design, customization, and on some projects we're even including this as a requirement for selecting systems so that you're able to try them out before you decide what to buy. And of course the objective is to try to make systems and technologies more effective and efficient, to try to reduce errors rather than accidentally introducing them, and to have systems and technologies that fit better into the health professional's daily work activities or workflow. And last but not least, to try to make these tools and systems more satisfying to use. I won't go into the detail on this slide. It's just a slide of what's known as the system development lifecycle. In development of any system or technology, you go through a number of phases, some of you may be familiar with, from the left-hand side, planning the system or technology, and then in phase 2, doing analysis or gathering the requirements of what you need. And stage 3, actually designing it. Stage 4 is implementing or programming it. And 5 is when you put it out there in the hospitals and the clinics, the support phase. And just on this, just to note that usability testing and the methods I'll talk about are really useful across all the stages. In the past, it was often just applied towards the end. And if you found a usability problem towards the end, it would be very expensive and difficult to change. So on projects I've worked on, we've tended to be doing usability testing back during implementation, even going farther back into design phases. And the project that Jennifer talked about, we're doing it with prototyping how to present information to clinicians integrated in EHR. So the earlier you do this, the better, as you'll see. The other question is, where can usability studies take place? And you've probably heard of $1 million usability labs with one-way mirrors. That's fine, but that's really not necessary. And as Joseph said, most hospitals could set up something that would be very inexpensive, that is portable. On the left-hand side here is laboratory-style testing, where you could do that in a lab, but you could also do it going into an office. It's just basically, it's artificial cases that you give the users. Somewhere in the middle is what we call simulations or clinical simulations, and I'll give one example today of the idea of a simulated doctor-patient interview to study technology. And on the far right side are in situ or naturalistic approaches, where if you really want to make sure the system is going to work well before releasing it across a whole hospital, you might try testing it in clinics or in live or near live settings. And I'll give an example today. So as Joseph said, the equipment for doing this isn't really very expensive, and I've done projects for 2 decades now all over the world using inexpensive equipment. You basically need some kind of software that will record what the user does on the screen as a movie file, and there's actually free software for doing this. If you have a Mac, you can use QuickTime, it's built in, and there's other free software for PCs. And you can turn the audio on and record what the person's saying. So that's one type of data we use, and I'll show you how we analyze it. The second type of data is from external video views. Hence I have the icon of the video camera there, where you might want to see not just what's going on in the computer, but what they're doing on the desk, what are they doing in the office, the clinic, or the operating room while they work with the technology. So this is just a picture of recording myself playing with a personal health record application, and the screens are being recorded to the laptop with the audio, and I'm thinking aloud. So that's being recorded, and it can be played back right afterwards in Windows Media Player. And the camera external camera on the tripod there would cover if I was, for example, looking at paper resources on my desk. So with those two sorts of data, you could do get an amazing amount of information about how to improve systems. And this is just a schematic of doing usability testing in a clinician's office. This is very much like what we did back in spring on the NIDA grant that Jennifer talked about, where we had the test participant, medical office assistant or physician, sitting down using the system at the desk, recording the screens, and we also had an external video camera. And the moderator there was the person that just runs the study and tells them what to step through when they're using the system. So this is very much like what we did. So I'll just, to show you how we analyze 2 or 3 simple examples to hopefully show you how the methodology works. So this was actually the first one I call Basic Usability Analysis of a Software Tool. This was actually the very first study I ever did in this in the it was actually 1990s. The objective was to determine how effective was the interface and content of a decision support tool that was being sent out for continuing medical education with guidelines about heart disease. So the data was having video recordings of doctors and students, there were 8 of them, interacting with the system, and we also audio recorded them thinking aloud while using the system, captured the screens, and did video coding. So I'll explain and take these apart. This is the actual coded transcript. So whenever we do these studies, you can watch the video and you can create annotations that go along with the video. So with the coding tools we use, you could click on a number there, 1 minute, 3 seconds, and then you can see the users looking at the introduction. The blue is annotations, and the black is what the user's saying as they're stepping through the system. You can see the user says, I've already had to loosen my tie, and it was annotated that they shifted in their seat when we watched the video, and then moves on to a risk analysis guideline recommendation screen. And this was done in the early 1990s, and the guidelines had all changed, and the system actually had old guidelines, and the users were very sensitive to this. Very first comment, my first comment is, this information is old, I don't know if it's been updated. So Joseph mentioned usability, but also usefulness. You could have a usable system, but it's easy to use, but if the information is out of date, it will be considered not useful. So you can watch what the user is doing in these type of logs. At some point on this slide, the user surveys the power bar and selects introduction, and then says, how do I fast forward? And on the video corresponding to this, you can see they're lost of how to go through the system. So that's coded as what we term a navigation problem. So since the 1990s, we developed a number of very simple and easy to use coding schemes for coding qualitative data for things like navigation problems, consistency problems. Eventually, the user says, is there no way out of this? And the experimenter says, you can kill us. So actually, this wasn't a really great application, and it was not changed because it was too late in the life cycle when the testing occurred. But having said that, I've worked with many applications, even till today, that still have some of the same problems and some of the same usability issues. As Joseph said, this didn't go away over time. So I'll just mention here, more recent work, got a lot of requests to develop video coding schemes. So we developed ones that are just sort of templates for looking at those human-computer interactions captured on video or screen recording. And for example, navigation problem, we gave a definition that's coded when a review of the video data indicates the user has problems moving through a system. So if a physician can't backtrack to a screen with patient allergy, can't find it, information, that would be a navigation problem, and we could code the exact spot it occurs. Consistency problem, coded if the video indicates there's a problem due to lack of consistency. In one of the major Canadian health surveillance system, we found one component of the system put month, day, and year in a different order than another component. So that was a serious problem that we found, and we coded that as consistencies. There are many different types of problems, like meaning of icons if someone doesn't understand what it means. And we've developed this scheme, and we've used it on many, many projects. So just to build up to what we did on this project and what we've done. sort of builds from doing projects sort of sequentially, and then now we're wrapping it together into one. But I'll just mention another type of project, another type of approach that extended usability testing to looking at, can we evaluate or characterize how physicians use technology in real clinical settings. So this was the idea of studying use of the electronic medical record when the patient was there. So this study also included doing basic think aloud usability testing, but we also recorded doctors interacting with someone playing the role of a patient or simulated patient while using the system. Borrowing the idea of the standardized or simulated patient for medical education, but now inserting the electronic record in it. So this was published just around 2000. This was a system, just one system we looked at. We looked at many electronic record systems, but this particular one was interesting. The idea was kind of a paper scroll metaphor that you'd ask the patient for the chief complaint and then click through the different categories of information on the screen, and you also had an electronic pen. So that was the system, and in order to study how it was used in the doctor-patient interaction, what we did on the picture here was basically have the participant or user use the system while interviewing the standardized patient. The screens would be recorded, which would be what the doctor was clicking on. In this case, the audio isn't thinking aloud, but rather it's the dialogue between the patient and the doctor. And also, you can see in this picture, we have an external video camera that's recording what's taking place on the desk. Do they use paper for a while and then move to the computer? In subsequent studies, we've looked at how the systems are used in actual doctor's office with more unobtrusive methods, like having a ceiling-mounted camera and going through IRB on that. But in this case, this was our first studies of looking at the technology in the context of a work activity. And the type of data we get from that are sort of at a higher level of granularity. This is an example. It was a narrative of a doctor-patient computer interaction using that system. And you can see, you can timestamp it and watch the video and see it took about 3 minutes when the physician reviewed the presenting complaint and started to load a template or filter, but stopped, and then decided to work without the system and work on paper for up to about 9 minutes, and then chose to go into the system. And the interesting thing was, once they're in the system, with this system, it tended to lead people to follow the categories of information on the screen, which is what we call screen-driven behavior. So not to say all systems do this, but we've seen with many other electronic medical records variants on this sort of guiding or screen-driven behavior. And it was very interesting. This was an experienced physician who knew that the system would do that and opted not to go in for about 9 minutes. So it was a demonstration that systems could affect, if they affect requests for information, they obviously affect reasoning, and it's an unintended consequence. So just to kind of put that together, we can look at conducting, and this sort of over time we did it chronologically, looking at simple usability testing and then clinical simulations involving simulated patients, and moving up this ladder. So at the bottom of this upside-down pyramid, we can say we often look at studying systems beginning with looking at the user interacting with the system in isolation. It makes it simpler to analyze. So we can determine if there's a basic usability problem that needs fixing. And if you fix that, that's okay, but then we also need to move up to the next layer, which is user interacting with the system and their environment to carry out a basic work task, which was the orange layer in the middle. An example of that would be using the system to do a doctor-patient interview and enter patient information. And then lastly, we move up this pyramid to multiple users interacting with the system, doing multiple tasks. On the right-hand side, I just mentioned the study approach. It's much simpler to look at users in isolation with the system doing usability testing, the basic approach on the first example. And then as we move up to more levels of complexity, we can look into doing simulations and finally doing naturalistic studies. And the last thing I'll show you is a study that incorporated all three of those. And just another implication of this, and this was from a recent paper in the Yearbook of Medical Informatics. As Joseph mentioned, safeties and usability become linked and have been a major issue. So our recommendations for development of IT included a phased approach, where in phase one you do some usability testing. Phase 2, correct defects. Phase 3, do clinical simulations, correct the defects, and then go into near live testing, and then don't release the system until you've actually gone through these layers. And just to end with, a very interesting study I was involved with Joseph on, published in 2012, was the title was Integrating Usability Testing and Think Aloud Protocol Analysis with Near Live Clinical Simulation in Evaluating Clinical Decision Support. And this was a study Joseph mentioned, the ICPR study that involved clinical prediction rules embedded in electronic health record. And so in the study, the same study, we employed several different phases of testing. In phase 1, we just had them sit down, this simple example at the beginning, step through the system and think aloud while using it, and we had 8 providers do this. Now, this involved triggering these prediction rules or alerts. And we also wanted to know how this would happen when the physician was interviewing a patient. So there was a digital patient created, and in phase 2, we conducted clinical simulations where the providers now interacted with the digital patient with the intent to find out how the rules triggered. And in stage 3, level 3, was a limited study of some live interactions. But the interesting thing is that each phase identified different types of issues. In the phase 1, the labeling of the button best practice advisory was difficult to see, and some people didn't know what it was at the time. But that was easy to fix. In the stage 2, we found some of the rules were triggered too early, as Jennifer mentioned, people are sensitive to, and Joseph as well, and some came too late. So the implications were this information was used to optimize the guidelines, leading to a resultant high uptake of the system. And so the process here involved the prototype, leading to level 1 basic usability testing, redesign fixes. Level 2 box, there's clinical simulation, and then more fixes. And then finally, it went live in a randomized control trial, as Joseph mentioned, with a high uptake and adoption. I won't go through here. These were just some examples of codes using this video coding approach, like the usability code, example coded statements. A user had said it's becoming a lot of clicking and reading, and you want to do this quickly, especially if you have a lot of patients there, so we include example coded statements. Visibility example, one user said, I just see the BPA here. Normally, I probably wouldn't see it since I don't usually look at that part of the screen. And workflow, one user said, I think it depends on when you start using the tool, because if you use it right from the beginning, you can get distracted and forget to go through other questions. So we're able to get a lot of information that fed back into optimizing. So I've mentioned some of these in the phases. In phase 1, basic usability testing, major usability issues have to do with things like visibility of system status, workflow, content, and understandability, for example, of labels or icons. And in phase 2 or 3, different workflows emerged, and very similar to what Jennifer talked about, different styles of using the guidelines, and the triggering of the advisories was explored, and then changes were made to optimize. And that's what I have on that. Thanks. Okay, I'll just start in with my lessons learned and then move on to Joseph and Jennifer. So one of the things is that issues related to human-computer interaction are really critical. We just can't provide information to end users without thinking about the technology. We need to test at multiple levels, from basic usability testing through to simulations. And the feedback from this should be integrated into refining and optimizing the technology, as Joseph mentioned, in a user-centered design process where you can make changes in cycles. And lastly, just some things we found out about clinical decision support is that it really needs to be tailored to provide information that the user wants, it's timely, and it's in a usable format. And to do this, we really have to assess the impact of the tool or technology on workflow. It must fit into the workflow and not be seen as adding undue time or effort. And that's why this is challenging in integrating this into electronic medical records, and why we need to study them in the context of real-life scenarios. And finally, systems or technologies should only be released after undergoing usability testing and optimization in order to ensure uptake. Thanks. And on to you, Joseph.
I'm going to talk about some things I observed. There are changes that can't be made was one of them. There are things you want to do with the EHR. There are changes you want to make. EHR functionality doesn't support. There's no way to do it, and that's frustrating because that means it's less than optimal usability. The trigger issue, which I talked about, context-sensitive triggers and ICPR, surfaced again, that there's a continuing challenge in EHRs where to put the trigger for the CDE, where to put the triggering event for the CDS. And we found that, we put in one spot, the users wanted another, and none of them were ideal. We also found the more rounds of usability you did, and even sometimes within the same round, you'd find conflicting views and comments. No, I always do it this way. No, I don't. And it's sometimes hard to interpret your usability findings in this context. We also observed what I would call the circular road, in which, we would make changes and then slowly find ourselves evolving back to the original changes. And it was kind of at times frustrating because it was, again, you have to interpret what they're saying and be careful because it can mislead you. So you can find someone saying, no, I need simple and simpler text. No, I actually need it more complex by the third round. A reminder that useful is determined by clinical leadership, or clinical leadership. So one of the challenges with this project has been our clinical leadership thinks this is a good idea to screen, but it hasn't become an imperative. It hasn't become one of the clinic or the practice priorities. It's not something we routinely do that much now. And that may affect the useful component, and that affects the, what they're willing to accept or not accept with usability, how driven they are to do it. They know not what they ask. Sometimes the users ask for things that if you're not in the room with the analyst, they can be misinterpreted because they don't know what they're describing something that doesn't exist or not quite exist the way they think. IT liked it. We had our analysts in one or two of the rounds, and they liked it because it was basically getting the same comments they would get during a go-live and have to make rapid corrections, but this way get in a controlled fashion early, make the changes, and not make a bad first impression. Overall, it made a significant change in our design, and it helped us avoid a lot of avoidable mistakes. I'm going to turn this over to Jennifer.
Okay, thank you. Oh, there they are. So I'm going to echo some of those same points, and this was my first experience with doing this type of building within the EHR and doing the testing. So I did learn a lot through the process. I think to state what is obvious to anyone who works in clinical settings, providers feel frustrated and pushed around by their EMRs, and basically, if you want to do something, to use the EMR as a tool, that it needs to support their work, and you can't dictate their work to a large degree by the tools that you build. It's really about showing the value of what you're trying to help them to do. If they think it's valuable, then they will probably use the tools if they're well designed. But if they don't think it's valuable, or they don't, or the tools aren't well designed, then they will either ignore them or work around them. And I think just to the level of frustration that people express during the usability testing, not necessarily with our tools alone, but just with their EMR in general, and this is a thoughtfully designed EMR, that you really can't underestimate how frustrated they feel. The constraints of the system itself, so we are working in Epic, but certainly every system would have its own limitations. And a couple of specific things that we encountered early on, and this is familiar to anyone who does substance use work and in an EPIC system is the social history section. So, EPIC gathers information on alcohol and drug use in social history. We looked seriously into trying to change that, and we're not able to make changes to it. And so we had to figure out a way of working around that without getting rid of it, and to try and integrate the information that we're collecting on screening with information that's already there in the EMR about alcohol and drug use. So that was a really significant early challenge, and we're limited. The other thing that we've talked about a little bit is just the struggle with matching the clinical workflow, and that the system isn't designed necessarily to do that. And here I have to take my hat off to the IT team, who thought very creatively about how you could manipulate the system in ways that it wasn't meant to be manipulated, but to achieve the outcome of things triggering when you want them to. And then the other point about there's a lot of variation in the styles of how providers use EMRs. And even since we were testing with residents and with faculty, we noticed real differences in how they would use the EMR. So the residents were more likely to look at the screen and write while the patient is sitting there with them during the visit, which means that you can provide them, information like guidance about what to say and when to say it, and then what comes next. But faculty tend to, know what they want to do during the visit and then maybe go back and document later. So that style of guidance wouldn't work for them because they may never open it when the patient's there. And by the time the patient has left, it's too late. And finally, it's interesting for this project, since we're building support within the clinic for doing screening, also at the same time that we're working on developing the tools, I feel like this process did help with buy-in. It helped us as a way of introducing a workflow and to sort of gently introduce this idea that we're going to be screening patients, and also helps, I think, to, at least with the folks who are there and who know that we were doing this testing, even if the tools in the end aren't perfect because of the limitations of the system, at least they know that we made a good effort, and I think that can help with buy-in for their use. And so that is our prepared presentation. I just want to acknowledge in particular the Mount Sinai Health IT team, who's worked very hard with us on this, developing the tools and the process, and also my team at the Greater New York node of the CTN. And we have some time for questions. So we'll open it up to the rest of the group. I think the lines are unmuted, so all you have to do is unmute your phone to talk.
Hi, this is Tim Willens. I had a question, maybe Andre, for you in terms of if you have, let's say, two competing builds for a CDS and you want to figure out which one works better, would it be reasonable to use your usability lab to test each one of them to see which one seems to be most efficient? Is that how you manage that? Or, I mean, how do you do that if you have two discrepant ways to do something and which way it seems to be the best way to do it?
Yeah, absolutely. I didn't mention, but comparative usability studies are quite good because you could do a between group study where two different groups, one group tries one system with the same task and the other group, or within group where the subjects try similar tasks on the two systems, which is really nice because then you can ask them to compare which design they liked better. And as we were saying today, people have different opinions about things, but if there's a clear difference between the two and one is superior, it will come out in this type of comparative usability testing. So yeah, that's an excellent. It's easy to modify the usability testing approach to compare two different designs explicitly.
Thank you.
This is Chris Shanahan. Thank you all. Thanks, Jennifer and Joseph and Andre, for an excellent talk. You know, you in presenting this, you have an incredibly difficult problem, right? Because you have to present the information that you gathered about this module that you plugged into a specific EHR, and we all know that EHR, like all EHRs, but I particularly think that's even worse, all have their own kind of usability limitations, and so it's just a really hard thing that you're trying to present here by the fact that you have these layers of usability. You have the actual shell, and then you're trying to make the module that you've created that interdigitates also usable on top of it. And sometimes it's very
I'm not sure that model is actually accurate because, number one, usability is about the human being interacting with the computer and what they see.
Mm-hmm.
You could make the argument that Windows is affecting the usability of the EHR, and number two, it's not a module. It's not something snapping on. It's something inside the EHR that they're seeing as part of EHR functionality. They were seeing this in the context of ambulatory EHRs. So I think Andre can talk to this, but I would argue I'm not sure that that's a great analogy because, you know, again, it would be like arguing I'm testing an app on iPhone, and therefore, what's the usability of the iPhone? It's whatever you're studying, it's equal.
Yeah, I mean, I see what you're saying, and you know, you didn't really present the module or should I say, the functionality separately. You talked more in general sense.
It's not a separate module or functionality. I can't express that enough. That's not the right analogy with Epic or the EHR we're using.
Anyway.
Yeah, I think you're saying, Joseph, it's the combined system that you're looking at, and you're looking at the user's interaction with that. But then when it comes to fixing it, then you really have to go to the different parts. Then you're looking at, do I make that change? Is it possible in Epic, or is it the guidelines layer? But from the user's point of view, it's a combined system.
Correct.
Right, so maybe your functionality is totally embedded in the application, and you're right. My statement about that is not accurate. You're really limited by the application's capacity and how it's set out.
If you were doing an assessment of spell checking in Word, you wouldn't say the spell checking module. You would just say spell checking function, or you know.
Okay. So I guess my point is that was the context, and so in designing something like this, I think a challenge is to how do you create an application, or how do you create an application that handles physicians and other providers that are not fully trained. In other words, they didn't pay attention. They're still doing work. You find it as a variation in how they do things, but actually some of them understand what they're doing much better than others. How can we build screens that are intuitive to even the most minimally trained? Those are the ones that are going to make the mistakes.
So I think there are two pieces to that. One is we did explain to them context and stuff like that, but we were using off-the-shelf functionality. We weren't building things that never existed before in the system. That said, if you look at our framework article on CDS, it helps with interventions like this to train them on the CDS, because although they're using it multiple times a day, there are things they don't realize or fully understand, and there are sometimes intricacies of, well, I know you usually don't do this, but you need to press here. It's part of the way it works. I mean, so it's a combination of those two, but it's not, I think I'm trying to get you out of, it's not some